Good morning, everyone. I'm Dr. Asim Hassin. Today, we'll be discussing preeclampsia and eclampsia. This is a crucial topic in maternal health, and I'm excited to share insights with you. Over the next few minutes, we'll explore the causes, symptoms, management, and prevention strategies for these conditions. Let's get started. Let's look at this case. A 32-year-old woman, pregnant for the first time, at 34 weeks gestation. She's admitted to the ICU with a headache and visual disturbances, which are concerning neurological symptoms. Her blood pressure is quite high at 168 over 112 mmHg, indicating severe hypertension. Her urine protein creatinine ratio is 45 mg per mmol, which shows significant proteinuria, a key marker of preeclampsia. Her platelet count is 85 billion per liter, which is decreased, suggesting some degree of platelet consumption or destruction. Additionally, her ALT level is elevated at 110 IUL, indicating liver involvement. Now, when we're asked about features that confirm severe preeclampsia, it's important to remember that severity isn't just about high blood pressure. It involves multiple organ systems. In this case, the high BP combined with proteinuria, low platelets, and elevated liver enzymes all point towards a severe form of preeclampsia. So the key features confirming severity here include the blood pressure, proteinuria, thrombocytopenia, and liver enzyme elevation. These are critical markers that guide us in managing the condition promptly to prevent complications for both mother and baby. All right, let's take a closer look at this question. The correct answer here is D now. The key point to remember is that severe preeclampsia is characterized by more than just proteinuria. While protein in the urine is a common sign, it alone doesn't define severity. Instead, we're looking for evidence of end-organ dysfunction. This can include things like a low platelet count, elevated liver enzymes indicating transaminitis, impaired kidney function, or neurological symptoms such as headaches or visual disturbances. So, in clinical practice, when diagnosing severe preeclampsia, it's crucial to assess these systemic signs, not just the presence of proteinuria. Recognizing these differences helps us determine the appropriate management and ensures we address the actual severity of the condition. This concept ties back to our overall theme of understanding the spectrum of preeclampsia and tailoring our approach accordingly. All right, let's look at this scenario. We have a 28-year-old woman at 36 weeks gestation who suddenly experiences a generalized tonic-clonic seizure while she's in the ICU. Her blood pressure is elevated at 170 over 115 mmHg. This is a critical situation that points toward eclampsia, which is a severe complication of preeclampsia. The immediate priority here is to control the seizure to prevent maternal and fetal harm. Now, among the options, IV diazepam is often used for acute seizure management. But in this context, we need to consider the underlying cause, severe preeclampsia or eclampsia, and the safest, most effective treatment. IV magnesium sulfate is the gold standard for preventing and treating eclamptic seizures because it's specifically effective in this situation, has a good safety profile when monitored properly, and helps reduce the risk of recurrent seizures. Other options like IV phenytoin or labetalol are used for seizure control and blood pressure management, respectively, but magnesium sulfate is the most appropriate immediate treatment for the seizure itself in this context. And an emergency cesarean section might become necessary if the mother's or baby's condition deteriorates further, but initially, stabilizing the mother with magnesium sulfate is the priority. So the key takeaway here is that in cases of eclampsia, magnesium sulfate is the first-line treatment for seizure control. It's essential to recognize this and act promptly to improve outcomes for both mother and baby. All right, let's look at the correct answer here, which is C. Magnesium sulfate is really the gold standard when it comes to treating eclampsia. It's used both to stop the seizures and, importantly, to prevent them from happening again. This dual role makes it essential in managing eclampsia effectively. Now, while benzodiazepines like lorazepam or diazepam can be used, they're considered second-line options. That means they're not the first choice, but they can be helpful if magnesium sulfate isn't available or if the patient doesn't respond. The key takeaway is that magnesium sulfate is the treatment of choice because of its proven efficacy in controlling seizures and reducing maternal and fetal risks during eclampsia. This is a crucial part of our overall management strategy for preeclampsia and eclampsia, emphasizing the importance of using the most effective, evidence-based treatments to ensure the best outcomes. Now, let's look at the options for managing blood pressure in this scenario. The key point here is that the woman has severe preeclampsia with a persistent BP of 180/118, but she hasn't experienced seizures yet. Our goal is to choose the most appropriate blood pressure management strategy. Option A suggests rapid normalization to less than 120/80. While aiming for good control is important, rapid normalization can sometimes cause issues like decreased placental perfusion, which we want to avoid. Option B proposes reducing blood pressure to less than 160/110 using IV labetalol. This is a commonly accepted approach in severe preeclampsia, controlling blood pressure to prevent complications while maintaining adequate placental blood flow. Option C recommends no blood pressure treatment until delivery, but in this case, her BP is dangerously high, so waiting isn't advisable. Option D suggests using ACE inhibitors, but these are contraindicated during pregnancy because they can harm the fetus. Option E proposes routine use of sodium nitroprusside, but this isn't typically used routinely in pregnancy and carries risks like cyanide toxicity. So the most appropriate approach here is to carefully lower her blood pressure to a safe range, avoiding rapid drops, which makes option B the best choice. It balances the need to control severe hypertension while minimizing risks to both mother and baby. This strategy aligns with our overall goal of managing preeclampsia effectively and safely. The correct answer here is B now. Let's break down why. The target blood pressure in this situation should be less than 160/110 millimeters of mercury. This threshold is crucial because it helps us prevent intracranial hemorrhage, which can be a serious complication. At the same time, we need to ensure that uteroplacental perfusion is maintained, so we don't compromise the baby's oxygen and nutrient supply. When it comes to medication options, the first-line choices are labetalol, hydralazine, or nifedipine. These medications are preferred because they're effective and generally safe for both mother and fetus. So the key takeaway is that managing blood pressure carefully in this context is essential to prevent severe complications, and choosing the right medication helps us do that effectively. This ties into the overall theme of safe hypertension management in pregnancy. All right, let's look at this case. We have a 35-year-old woman with preeclampsia who's deteriorating in the ICU. Her labs show her hemoglobin is falling, which suggests ongoing bleeding or hemolysis. Her platelets are down to 60,000, indicating thrombocytopenia. Her AST level is significantly elevated at 350 IUL, and her LDH is markedly high. These findings point toward a hemolytic process affecting her liver and blood components. Now, considering the options, we need to identify the most likely diagnosis. Acute fatty liver of pregnancy typically presents with liver dysfunction, but doesn't usually cause such severe hemolysis or low platelets. TTP, or thrombotic thrombocytopenic purpura, can cause microangiopathic hemolytic anemia and thrombocytopenia, but liver enzyme elevation isn't as prominent. DIC, or disseminated intravascular coagulation, involves widespread clotting and bleeding, but the key features here are more aligned with another syndrome. Sepsis can cause many of these signs, but the lab pattern here, especially the hemolysis indicated by high LDH and markedly low platelets, points more specifically toward HELLP syndrome. HELLP stands for hemolysis, elevated liver enzymes, and low platelets, and it's a severe complication of preeclampsia. This presentation matches perfectly. So based on this, the most likely diagnosis is E, HELLP syndrome? The correct answer here is E. Let me explain why. HELLP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. It's a serious obstetric emergency that can pose significant risks to both mother and baby. When a patient presents with these signs, it indicates a potentially life-threatening situation. Because of the severity, HELLP syndrome requires immediate attention, often necessitating ICU care to stabilize the mother. The definitive treatment is usually urgent delivery, as this can be the most effective way to resolve the condition. Throughout this presentation, we've been emphasizing the importance of early recognition and prompt management of obstetric emergencies. HELLP syndrome is a prime example of why quick action is critical to improve outcomes. All right, let's look at this question about managing a patient with eclampsia at 33 weeks gestation. The key point here is that, while magnesium sulfate has been effective in controlling seizures and blood pressure has been stabilized, the question remains, what is the definitive treatment? Now, among the options, continuing magnesium for weeks isn't typically recommended as a definitive solution. It's more of an acute management tool. High-dose steroids can be helpful for fetal lung maturity, but they don't address the maternal condition directly. Immediate delivery once the mother is stabilized is often considered, but we need to think about the timing and the gestational age. Delaying delivery until full term might risk maternal or fetal complications, especially at 33 weeks. Renal replacement therapy is not a standard treatment for eclampsia itself. So, connecting all this, the most appropriate choice here, given that the mother is stabilized at 33 weeks, is to plan for delivery. This aligns with the overall goal of resolving the pregnancy to prevent further complications. Therefore, the best answer is C, immediate delivery once the mother is stabilized. The correct answer here is C now. Let's talk through why that is. The key point to remember is that the only definitive cure for preeclampsia and eclampsia is delivery. This means that, ultimately, the baby has to be born to resolve the condition completely. Of course, before we proceed to delivery, maternal stabilization is crucial. We always prioritize stabilizing the mother's condition first, ensuring her safety and well-being. Only once she is stabilized can we move forward with delivery. This approach helps minimize risks and ensures the best outcomes for both mother and baby. Understanding this sequence is essential as it ties into the overall management of preeclampsia and eclampsia, emphasizing that delivery is the definitive solution. Let's start with the basics. Preeclampsia is defined as new-onset hypertension that occurs after 20 weeks of pregnancy, specifically when blood pressure readings are greater than 140/90. But it's not just about high blood pressure. Organ dysfunction also plays a key role in this diagnosis. When blood pressure rises to 160/110, or if there's evidence of end organ damage, we consider it severe preeclampsia. This indicates a more serious condition that requires close monitoring and management. Eclampsia, on the other hand, is essentially preeclampsia that progresses to seizures. It's a critical escalation and highlights the importance of early detection and treatment of preeclampsia to prevent such severe complications. Throughout this presentation, we'll see how understanding these definitions helps us identify at-risk patients early and implement appropriate interventions to safeguard both mother and baby. Let's take a closer look at the pathophysiology behind preeclampsia and eclampsia, which is really key to understanding these conditions. First, abnormal placentation leads to endothelial dysfunction. This means the lining of the blood vessels isn't functioning properly, which sets off a cascade of issues. One major problem that arises is vasospasm, or the constriction of blood vessels, which causes reduced blood flow and ischemia, essentially tissue and organ damage due to lack of oxygen. Another important point is capillary leak, where the blood vessels become more permeable than they should be, leading to pulmonary edema, fluid buildup in the lungs, which can cause breathing difficulties. And finally, hypercoagulability, or increased tendency for blood clotting, can contribute to serious complications like HELLP syndrome and DIC, which involve widespread clotting and destruction of blood cells. All of these mechanisms are interconnected and contribute to the clinical features we see in preeclampsia and eclampsia. Recognizing how these processes work helps us understand why these conditions are so complex and why they can affect multiple organ systems. Now, let's discuss the indications for ICU admission in obstetric patients. These are critical conditions where intensive monitoring and management are essential. First, eclampsia, which involves seizures in a pregnant woman with preeclampsia, definitely requires ICU care to control seizures and monitor both mother and baby. Next, severe hypertension is another key indication, especially when blood pressure reaches dangerously high levels that can threaten organ function. Then we have HELLP syndrome, a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. This condition demands close supervision and aggressive treatment in the ICU. Pulmonary edema is another serious concern. Fluid overload in the lungs can impair breathing, so these patients need ventilatory support and careful fluid management. Acute kidney injury, or AKI, can develop rapidly and compromise renal function, requiring specialized care. Altered consciousness is also critical. If a patient shows signs of neurological deterioration, ICU admission ensures we can provide the necessary interventions promptly. Finally, preeclampsia and eclampsia themselves are major reasons for ICU admission, given their potential to escalate rapidly and affect multiple organ systems. Overall, recognizing these indications helps us intervene early and prevent serious complications, ensuring the safety of both mother and baby. Now, let's talk about seizure control in preeclampsia and eclampsia. Magnesium sulfate is our mainstay treatment. When administering it, we start with a loading dose of 4 to 6 grams given intravenously. This helps quickly reach therapeutic levels. After the loading dose, we maintain the therapy with a continuous infusion of 1 to 2 grams per hour to keep magnesium levels effective. While the patient is on magnesium sulfate, it's crucial to monitor certain signs closely. Watch the reflexes, especially the patellar reflex, because loss of reflexes can indicate magnesium toxicity. Keep an eye on the respiratory rate, ensuring it stays above 12 breaths per minute, because respiratory depression is a serious risk if magnesium levels become too high. Also, monitor urine output to make sure the kidneys are effectively excreting magnesium. Less than 30 ml per hour could be a warning sign. In case of magnesium toxicity, the antidote of choice is calcium gluconate. Administering calcium helps counteract the effects of excess magnesium, especially if the patient develops respiratory depression or lost reflexes. This approach is essential in managing seizures and preventing complications in women with preeclampsia or eclampsia, tying into our overall goal of safeguarding both mother and baby. Let's talk about blood pressure control in preeclampsia and eclampsia. First-line agents are crucial here. IV labetalol is often the go-to because it effectively lowers blood pressure with a good safety profile. IV hydralazine is another option, especially useful in acute settings. Oral nifedipine is also commonly used, especially when IV access is challenging or for ongoing management. However, there are medications we want to avoid in this context. ACE inhibitors and ARBs are contraindicated because they can be harmful to the fetus. Similarly, nitroprusside should be avoided due to the risk of fetal cyanide toxicity, which can be quite dangerous. The key takeaway is to carefully select agents that effectively control blood pressure while minimizing risk to both mother and baby. Proper management of hypertension is vital to reduce complications in preeclampsia and eclampsia, helping improve outcomes for everyone involved. Now, let's talk about HELLP syndrome. This is a serious condition that can sometimes develop rapidly, leading to swift deterioration in the mother's health. It's important to recognize that HELLP syndrome carries a high risk of maternal mortality if not managed promptly. Because of its severity, the typical approach involves intensive care unit admission and urgent delivery of the baby. This is often the best way to protect both the mother and the baby once the condition is diagnosed. You'll notice that HELLP syndrome is closely related to preeclampsia and eclampsia, which are part of the spectrum of hypertensive disorders in pregnancy. Understanding this connection helps us appreciate the importance of early detection and management of hypertensive conditions during pregnancy to prevent progression to such severe complications. Now, let's discuss definitive management and delivery. The timing of delivery really depends on several key factors. First, gestational age plays a crucial role because it influences the maturity of the fetus and the risks involved. Next, maternal stability is vital. If the mother is stable, we might have more flexibility, but if she's unstable, urgent intervention could be necessary. Additionally, the fetal condition is a major consideration. We need to continuously monitor fetal well-being to decide the best course of action. When it comes to preeclampsia and eclampsia, these conditions require careful management because they can rapidly become life-threatening. Our approach must be tailored to each individual case, balancing the risks and benefits to both mother and baby. Ultimately, the goal is to ensure the best possible outcome for both through timely and appropriate intervention. Let's go over some key pearls for managing preeclampsia and eclampsia in the ICU. First, magnesium sulfate is not an antihypertensive. Its primary role is to prevent and treat seizures, but it doesn't actually lower blood pressure. Next, if a patient has a seizure during pregnancy, we should think of eclampsia until proven otherwise. Seizures in this context are a serious sign, and prompt recognition is crucial. It's also important to note that proteinuria is not required for diagnosis. While traditionally we looked for protein in the urine, recent guidelines emphasize that other signs can be sufficient to identify preeclampsia. Additionally, HELLP syndrome, hemolysis, elevated liver enzymes, low platelets, can occur even without severe hypertension. So, absence of high blood pressure doesn't exclude this diagnosis. And finally, while magnesium helps manage seizures, delivering the baby is actually the definitive treatment that cures the disease process itself. Magnesium doesn't resolve the underlying pathology, delivery does. Remember, the overall goal is to stabilize the mother, control the seizures, and plan for delivery to resolve the condition completely. Thank you so much for your time and attention today. I really appreciate you being here and engaging with the content. I hope that the insights we've discussed have been helpful and have given you a clearer understanding of the key concepts. Remember, the ideas we've covered are all about driving progress and making meaningful changes. If you take away one thing from today, I hope it's the importance of applying these principles in your own work and projects. Thanks again for being such a great audience, and I look forward to seeing how you'll implement what you've learned.